Get started. We've given the customary 1 minute. So I don't think our speaker today really needs an introduction, but I'll go ahead and give one. So Dr. Ty Carroll is a professor of medicine and now the chief of the Division of Endocrinology, Diabetes, and Metabolism at the University of Wisconsin School of Medicine and Public Health. He received his medical degree and completed, I think, all of his postdoctoral training here at the Medical College of Wisconsin, where he was a faculty member and also the program director up until late last fall. His, I think, clinical and also research interests include patients with cortisol excess. And so today he'll be speaking on a current view of cortisol excess from Cushing to Commonplace. So Ty, we're very excited to have you back and we're looking forward to your talk.
Thank you so much. I have to admit, I think that's the first time I've been introduced as not having my entire career here at MCW. So, wow, this is really loud. So,
I don't think you need that.
Yeah, Angela's going to turn it down for me. All right. Yeah, you can go down farther. I talk loud enough even without the mic. This is really just for the online people. Great. Well, it's fantastic. That's good enough. I can turn it down if we need more. It's great to see a whole bunch of friendly faces and some faces I'm sure that are joining us virtually. So thanks for coming. My number one goal today is to make sure nobody falls asleep. So if anybody starts to nod off, I'm going to walk over and shake you a little bit. No, but I'm going to talk about cortisol excess and Cushing syndrome. These are my disclosures. What we're really going to talk about is I'm going to start with a little historic perspective. I think that kind of gives us a nice backdrop. Then we'll do a little bit about testing. Don't really need to do too much of that with this crowd. Talk about mild cortisol excess. And then really some of our work that was recently published on prevalence or incidence of Cushing syndrome. Talk about why Cushing syndrome is or isn't important, and then finally talk about treatment and medical surgical therapy, and then maybe some future directions. So a little history lesson. Some of the people in the room need this more than others. So if we go back to the beginning, in 1912, when Dr. Cushing first described this patient, Minnie G, that had classic signs and symptoms of what would become Cushing syndrome: facial rounding, plethora, violacistria, central obesity, proximal muscle weakness, kind of all the hallmarks of what we now know as Cushing syndrome. And the remarkable thing about this was in 1912 and 1932, the kind of paper about a pituitary tumor that caused or was thought to be the cause of these symptoms. I mean, this was all before we actually knew what cortisol was, because in 1935 and subsequently the discovery of compound E cortisone and compound F cortisol was made, and in 1950 led to the Nobel Prize. Oh, sorry, I forgot to do Cushing. It led to the Nobel Prize from these three gentlemen, Kendall, Reichstein, and Henk, who received the Nobel Prize for the discovery of cortisol and its use to treat rheumatoid arthritis initially. So Cushing described all this before we actually even knew what cortisol was, which is pretty remarkable. Leap ahead about 10 years, and there are descriptions of the dexamethasone suppression test in urine-free cortisol for the diagnosis of Cushing syndrome. Certainly the dexamethasone suppression test, not what we think of now with the 1 milligram overnight, but testing for cortisol excess nonetheless. Then we get to the 80s and 90s and the first descriptions of late-night salivary cortisol, and certainly going back and reading some of this literature, and this in particular really kind of piqued my interest. Obviously, Jay and Herschel's work in salivary cortisol was really paramount in a new way to diagnose Cushing syndrome. So also in the 80s, there was description of subclinical Cushing syndrome, a term that we don't really use anymore or trying to get away from using, patients that have lesser degrees of cortisol excess, and we'll talk about this in a minute. Another 30 years into the future, and the first guidelines on adrenal nodules really say that everybody that has an adrenal nodule should get testing for. So important now that we agree that everybody that has an adrenal nodule should get tested. There's also a lot of literature from the 2010s about the cardiovascular risk and other risks in patients with milder forms of cortisol excess. And then that kind of brings us up to today when we use the term MAX, that mild autonomous cortisol secretion. Jay and I, we really were pushing for MCE, the mild cortisol excess, but max 1. I guess it's a little, rolls off the tongue a little bit easier. All right, so that's your history lesson for the day. A little bit on diagnostics. Like I said, this group doesn't really need too much introduction to the diagnostic testing for cortisol excess. But if we're talking about cortisol excess, we need to talk about dexamethasone suppression, late night salivary cortisol, and urine-free cortisol. So these numbers about sensitivity and specificity are really from patients that have overt cortisol excess. So I think when we start to talk about mild cortisol excess, these numbers don't quite hold up. So just keep that in mind. If we're looking at the dexamethasone suppression test, extremely good sensitivity, specificity not as good, around 81%. Urine-free cortisol, not great sensitivity, especially as that degree of mild cortisol excess gets less and less. And then salivary cortisol, a good balance between both sensitivity and specificity. But again, this is in patients who have overt Cushing syndrome or cortisol excess. And I guess let me kind of just take a step back. The thing I neglected to mention before, I'm going to kind of use both terms, cortisol excess and Cushing syndrome. I really try to use cortisol excess to talk about the spectrum of this problem. So mild cortisol excess all the way up to florid problems with cortisol excess. And when we talk about Cushing syndrome, it's really hypercortisolism and those clinical manifestations of patients that have excess cortisol. All right, so those are the tests, but I think actually more importantly is to kind of talk about what are the times when we have problems with these tests. So the confounding issues, and certainly exogenous steroids are a big problem, both the ones that we know about and the ones that we don't. So patients that get joint injections, spine injections, hip, knee, patients that have topical steroids, there's some data that show that some large joint injections that steroid may last for a year it's detectable in the plasma. So really important that we ask patients about this. And also realizing that patients are on a lot of supplements. There's good data that many of these supplements have unreported amounts of glucocorticoid in many of them. And so that can throw off our testing depending on what that glucocorticoid is that they're taking. And then the issue of non-neoplastic hypercortisolism. So these are patients that have real elevations of cortisol, but it's not from a tumor. So it's not from an ACTH secreting pituitary tumor. It's not from an adrenal nodule. It's not from ectopic source of ACTH production. We sort of used to call this pseudo Cushing's. We're really trying to get away from that because these patients really have excess cortisol and it's endogenous. It's just not that it's from a tumor. It may be physiologic. And here's my shameless plug for the ACE podcast that Jay and I did recently. So the link's on there if you can copy that down real quick, or just Google the ACE podcast series. It's a great series, and thanks to Jennifer suggesting us to do this. It's a discussion of non-neoplastic hypercortisolism. So these patients can be really difficult to figure out, is it from tumor or is it not? A lot of things can cause excess cortisol, uncontrolled diabetes, sleep apnea, any number of issues. So what can we do in terms of testing? And at this point, probably the best test that we have is the desmopressin test. So the theory here is that patient gets desmopressin. Desmopressin binds to the vasopressin receptors, and pituitary tumors, or I should say choricotroph-adenomas, so tumors that are making ACTH, express the vasopressin receptor maybe in greater amounts than normal corticotrophs, or they're just more of them. And so when you give vasopressin, there's a stimulation and ACTH levels go up drastically. Cortisol levels tend to go up as well. So pretty good sensitivity, kind of around 90%, specificity 94% for this test in this meta-analysis. So it's a good test. It's the best thing that we have currently to try to distinguish ACTH-dependent cortisol excess from Cushing's disease versus patients that have non-neoplastic causes of hypercortisolism. All right, and then kind of the last confounder that I throw in here are lesser degrees of cortisol excess. And I think one interesting thing to think about is progression of disease. So those of you who have been in endocrinology long enough know that our thought about a lot of these things changes over time. And I remember distinctly as a fellow reading about the testing of Cushing syndrome, and the way that a test was decided if it was a false negative or false positive or not is that many of these patients were followed for 3 to 5 years. And at the end, if they hadn't developed overt Cushing syndrome, then if they had a positive test previously, it was thought to be a false positive. And there was this belief that patients that had Cushing syndrome would always progress as we followed them for long periods of time. We know that that's not true now. And in fact, the 2023 adrenal nodule guidelines from the European Society actually say that they recommend against considering that patients with MACs are going to develop Cushing syndrome. So just because you have mild cortisol excess now doesn't mean that you're going to have severe cortisol excess in 5-10 years. And it's that low level of cortisol excess over time that causes the cardiovascular risk, diabetes, osteoporosis, et cetera. So a little bit about MACs, and as I was looking at these slides, I realized I forgot the secretion. They should say mild autonomous cortisol secretion or MACs, because I guess right now it's just MAC. So what is MACs? Well, probably the most concise definition here is, again, from these 2023 guidelines. They really say they would consider anyone who has an adrenal nodule, does not have classic symptoms of overt Cushing syndrome, and has an abnormal dexamethasone suppression test, that they have MACs. They add in here that we don't need to go further and stratify what level of cortisol. Previous adrenal nodule guidelines talked about cortisol levels above 1.8 and then above 1 or above 5. And so they really just said, if it's above 1.8, that's abnormal and that's max. So the problem with this, in my view, and I like to kind of poke people about this, is who gets to decide if a patient has signs and symptoms of overt Cushing syndrome? Is it me? Is it Dr. Finling? Is it the primary care doctor who's seen one case of Cushing syndrome that they realize? How bad do these signs and symptoms of overt Cushing's need to be? How many do they need to have? So if you've got a little bit of facial rounding, a little bit of plethora, is that enough? I don't know. And when we kind of introduce this vague part of the definition, it gets to be a little bit harder to kind of draw a line and say, okay, well, that's max, that's not. And I think that's why using the term hypercortisolism is a little bit better than saying Cushing syndrome, because we don't have to rely on kind of subjective signs and symptoms. And the other part of it is we're talking about a test that has an 81% specificity. And so we really should be careful in saying a single test. We really want to prove that patients have persistent abnormal response in any of the tests. So if we're talking about dexamethasone suppression testing, should be done at least a couple of times and make sure that it's abnormal repeatedly. All right, so been talking about cortisol excess, probably could have led with how common is this, but pretty common, we would say. So I think you'll all recognize the state of Wisconsin. I think arbitrarily you got to do this if you're from Wisconsin, because we're right here. So this is some data that was recently published. Tommy Matoska, who's now a radiation oncology resident here, did a lot of work with us. And we looked at our Cushing syndrome database and tried to figure out what the incidence of Cushing syndrome was for the patients that we had seen. Older data would suggest that the incidence is somewhere between 1 to 3 cases per million per year, and that didn't really seem to make any sense. So we looked at the incidence by county, and what we found is that if we looked at all types of Cushing syndrome, we found 185 patients who had documented Cushing syndrome diagnosed here at MCW and also had treatment. So they weren't patients that had MACs and were followed conservatively. These are all patients that the vast majority underwent surgical therapy. Very few had medical therapy because they had comorbidities that wouldn't allow surgery. And we found 7.2 cases per million per year. And then also acknowledging that we don't see every case of Cushing syndrome here that's diagnosed in Milwaukee. Other healthcare systems see patients. And when we adjust for the portion of patients that we see throughout the state, there's some data about how many patients in the state are discharged from hospitals that have cortisol excess. And we see about half those patients. So when you do this calculation, we end up with about 11 and a half cases per million per year. Far greater than that 1 to 3 cases per million per year. So we think that the incidence of Cushing syndrome is a lot higher. Now, one sort of other important finding is that we found that 111 of these 185 were adrenal. So typically, if you look at the textbooks, they'll say that 85% of Cushing syndrome is pituitary, so it's Cushing's disease. That's just not our clinical experience, and found a much higher percentage had adrenal Cushing, so about 7 cases per million per year were just adrenal. Again, one criticism here is that, well, these are just patients that have MACs, and that's why this seems so much higher. That's true to some degree, but again, these were also patients that had cortisol excess bad enough to warrant surgical therapy. So it's probably significant enough to say this is real disease. And then the other thing is, what about these classical physical features? So we talked about MACs and lacking classic physical features. So if we break it down by etiology, if we look at the patients with ectopic disease, all of them had physical features. Even in Cushing's disease, only 90-ish% had physical features, and then only about 45% of the adrenal nodules had classic physical features. So we found also that the degree of cortisol excess correlated with the amount of classic physical features, which kind of makes sense. But even at that 44%, these patients had other biochemical manifestations and other comorbidities that led them to get treatment. All right, so other hypercortisolism. So we've kind of talked about MACs and some other things. This is where we get to the Catalyst trial and start with part 1. So those of you who are unfamiliar with the Catalyst trial looked at patients who had poorly controlled diabetes. They defined that as patients who had an A1C between 7.5 and 11.5, and then also were either on multiple medications, so 3 medications or more, were on insulin, were on multiple diabetes, hypertension medications. So these are kind of the typical patients that we see in clinic. They've got diabetes that's not well controlled. They're on a bunch of medications. And everybody got a dexamethasone suppression test, and they were really looking to see what percentage of these patients had an abnormal dexamethasone suppression test. After that, then they did some additional testing, which we'll talk about. But what they found is that almost a quarter of these patients had an abnormal dexamethasone suppression test. I don't think that any of us thought that it was going to be this high. I don't know, maybe a few people in the room thought that, but I certainly didn't think it was going to be almost 25% of patients that had abnormal dexamethasone suppression tests. And when they looked at the subgroup that was taking 3 or more antihypertensives, it was a third of those patients had abnormal dexamethasone suppression tests. So really pretty surprising the amount of patients that had cortisol excess. So then some of the commentary as well, are these just patients that have MACs? Well, they did adrenal imaging, and only about a third of patients had an adrenal abnormality. So 2/3 didn't. So I can say 2/3 of these patients that had abnormal DSTs didn't have MACs because they don't have an adrenal nodule. If they look at the relationship to cardiovascular disease, so if you had an abnormal DST, a third of those patients had cardiovascular disease. Only about 20% of the patients with normal DSTs had cardiovascular disease. And then some other independent risk factors. So the older a patient was, they were more likely to have an abnormal DST. The leaner they were. So if you had a BMI less than 30, if you think about that, it may make sense. We know that significant obesity can lead to poorly controlled diabetes, hypertension. But when you're leaner, maybe there's something else that needs to drive that diabetes and hypertension, and maybe it's cortisol. So certainly something to think about. And then the other question is about ACTH. So again, were these just all MACs? And the short answer here is probably not. They did not see any correlation between the post-DST cortisol and the ACTH. In the patients that did have an adrenal abnormality, those patients had lower ACTHs. So some of those, that 30% or 1/3, probably had MACs, but it's unclear as to the rest of these patients. So what is this population? I don't really know. I don't think that they're all MACs because, again, only a third had an adrenal abnormality. Are they something else? I think so. Is it non-neoplastic hypercortisolism? what I don't really know, and I don't think anybody does, is what's the chicken and what's the egg. So do they have poorly controlled diabetes, hypertension that's causing hypercortisolism? Or do they have hypercortisolism that's causing those issues? We just don't know. And I think the bottom line is, well, do they need to be treated? And we'll talk about that a little bit later. All right, so the next question is, what about MAX? Is it important? So I think you all are going to guess that I'm going to say it's important, but I still have to prove it to you. So meta-analysis that looked at patients with MAX versus patients who had non-functional adrenal adenomas. So in this study, it's a meta-analysis of these 5 studies. This vertical line, anything to the right, is that MAX has more mortality. If we look to the left, that would mean that non-functional adenomas had more mortality, and on the line is they're the same. If we look at the pooled data here, it shows about a 50% increase in mortality in the MAX group. So certainly a significant increase in mortality. Then if we look at diabetes, there's a lot more studies that looked at diabetes, and they broke them out into different levels of cortisol after the DST. But if we just focus in on the pooled group, so anybody that had an abnormal DST, this shows that about 45% of patients, or there was a 45% increase in the risk of having diabetes if you had MAX as opposed to having a non-functional adrenal adenoma. So you die more often, you have more diabetes. That sounds important to me, but to add to it, there's also other cardiovascular risk. There's a whole host of studies that looked at cardiovascular disease risk and showed that on a spectrum, anybody that had a DST cortisol greater than 1.8 had higher cardiovascular risk. Some studies show that adrenal nodule size may play a role. That may make sense because bigger nodules tend to produce more cortisol. And then one important other kind of consideration here is what happens if we follow these people over a long period of time. So one study had a mean follow-up of 7.5 years, and they looked at patients with adrenal nodules. Everybody got a DST to start. And they broke them into 3 groups: normal, so less than 1.8, abnormal with a cortisol of 1.8 to 5, and then above 5. And then they followed and then did another DST at the end. And what they saw is that 12% of patients actually went up or had worse cortisol secretion at the end of the follow-up. So if you were normal, they went to abnormal. If you were in that first abnormal group, they went to the higher group. And 6% that were normal to begin with had abnormal cortisol secretion at the end. So the reason I bring this up is that some of the recent guidelines talk about what follow-up we should do with patients with adrenal nodules and normal initial testing. And the recommendation's kind of vague about, well, they can get retested if they develop new signs and symptoms of cortisol excess. Who's doing that is my question. Because if we send them back to primary care, the chances are they're probably not going to get retested for cortisol excess. If we keep them, we're all going to be seeing a whole bunch of patients that have normal DSTs and adrenal nodules. I don't know what the right answer is. I don't know when we should think about rescreening these people. I'd love to hear people's suggestions about that as we kind of move to questions in a little bit. So how do we treat this? And does it have an impact? So these great 2023 European guidelines talking about MAX and gives a very vague answer. So if somebody has MAX, you should think about surgery and their comorbidities and their choices. Hand waving. Yep, patient-centered decision-making, great. But no hard, firm answers about what we should do. And I think the reason is because we don't really know. We're not sure what the best treatment is for these patients. There are studies that have looked at surgery versus conservative management. And in this meta-analysis, so anything to the left is treatment, meaning unilateral adrenalectomy, is better, and anything to the right is that conservative management is better. And so if we look at this, you were about 40% more likely to have a decline in your BMI if you had surgery as opposed to not having surgery. So if you have MAX and you get your adrenal gland taken out that's causing the excess cortisol, you lose weight. Now switching back to treatment is better on the right, and we're looking at blood sugars. And this study broke out the randomized controlled trials, the cohort studies, and then put them together. I'm just going to focus here on the group where you put the two groups together. And you were 8 times more likely to have improvement in glucoses if you had adrenalectomy, if you have MAX. And that's true both in the randomized controlled trials and the cohort studies. So when you pool those together, a pretty significant improvement in glucoses with surgery. And blood pressure, same thing. If we look at the pooled data, we're talking about patients that were almost 9 times more likely to have improvement in blood pressure if you have adrenalectomy as opposed to conservative follow-up. So this would certainly suggest that having an adrenalectomy if you have MAX is beneficial. Weight goes down, blood pressure goes down, glucose goes down. What about medical therapy? Not everybody that has mild cortisol excess that doesn't really have symptoms is going to want to have surgery or maybe is a candidate for surgery. So for a second, I'm going to veer off into not quite MAX, but back to that Catalyst trial. So remember, these are not patients with MAX. They're poorly controlled diabetes and abnormal DEX suppression tests. So 91 patients got mifepristone somewhere between 300 and 900 milligrams once a day. And they followed those patients for 24 weeks. And the goal was to see what the A1C was at week 24. And so the A1C went down significantly. So at the end of 24 weeks, the mifepristone group went down almost 1.5, and the placebo went down a very small amount. So about 1.3% decline in A1C. So pretty significant. Going from an 8.3 to a 7 at 24 weeks is really something. And to kind of put this in perspective, this study to the right, so this is baseline. I don't have the weeks on the bottom, but this line is actually 25 weeks. And if we look, the red line is placebo, and these two lines are pretty much overlapping, but they're here, 1.4 and 1.5 decline in A1C. Does anybody want to guess what these are? I guess I don't have the reference on there, sorry. This is semaglutide 0.5 and 1. So mifepristone had almost the same decline in A1C as semaglutide 0.5 milligrams. It's not 1, it's not 5, or it's not 2 milligrams, but it's a pretty significant decline nonetheless. That being said, I think we also have to think about what are the downsides that happened in this trial. Well, some of the other good things, more patients got off of their glucose-lowering medications. Patients had a significant decline in weight, about 10 pounds. They had decreases, obviously, in their BMI and their waist circumference, but they did have side effects that were pretty similar to the known side effects from mifepristone. But the important things, fatigue, nausea, vomiting, and then the big one, increase in blood pressure. So remember that mifepristone is a glucocorticoid receptor antagonist, so you're blocking the effect of cortisol on the receptor. Cortisol levels actually go up and can go up significantly when you start mifepristone. And then the physiology that I love to talk about. So Herschel would be so proud of me. So remember, in the kidney, you've got the beta HSD2 that transforms cortisol into cortisone. Cortisol can bind to the mineralocorticoid receptor. Cortisone can't. So if you've got a perfectly functioning system, cortisol gets deactivated to cortisone and none of it binds in the kidney. If you have too much cortisol, you overwhelm that enzyme and you get cortisol that then binds to the mineralocorticoid receptor in the kidney. That's the thought here, and you essentially have aldosterone effect from cortisol in the kidney. So blood pressure goes up, potassium goes down. A third of the patients in this trial needed to get started on essentially spironolactone, and only 2% in the placebo group. So I think that that's important because if you look at the actual numbers, systolic blood pressure went up by about 10, diastolic blood pressure by about 4. That's a pretty significant increase. So I'm not sure this is kind of ready for prime time. Perhaps the other agent that's a glucocorticoid receptor antagonist, relacorilant, which doesn't seem to have this effect, may have benefit, but that remains to be seen in the clinical trials.
That's prior to starting the spironolactone?
That's a great question, and I don't want to mislead you. I don't remember it is. Jay, do you remember, is this prior?
Problem with this is that here this is a randomized double-blind trial, so the investigators did not know who was on mifepristone and who was on placebo. So there was no preemptive strike to follow. I mean, they all on potassium, but there was no, patients on mifepristone typically get put on potassium or lactose, particularly if they have any history of that. So that explains some of this dramatic blood pressure increase and hypokalemia, which was a major reason of the patients fell out. But I think most of these differences, some patients were on spironolactone, so that may, I'm not real sure. I'm sure the data is there, but I don't know what.
Yeah, it's a great question, Sylvia. I don't remember if this was before or after the spironolactone. I'll have to go back and look. So kind of, again, shifting away from that population with poorly controlled diabetes and moving back to MAX. Medical therapy. The problem that we have is, what are we treating? Because if we're treating a biochemical goal, we know that patients that have overt Cushing syndrome, they have a high UFC, you put them on a medication, we follow that, we try to normalize those levels. That makes great sense. What about patients with MAX? They probably have normal UFCs. They may well have normal salivary cortisols and may only have elevations in DST. So are we following DST levels in these patients? Can't really follow their clinical symptoms because by definition, they don't have clinical symptoms. Do we follow their comorbidities? With a lot of other conditions with primary aldosteronism, yeah, we follow the blood pressure, right? So do we follow patients, blood pressure, diabetes, weight, those things, and not care so much about, the numbers? It's a question that nobody really knows the answer to. And the other issue is when we give medications that block the synthesis of cortisol, we kind of across the board lower cortisol levels. And is that affecting the cyclicity of cortisol? Obviously, we want to keep that circadian rhythm, that highest in the morning, reach a really low point late at night. It looks like that low point, that nadir, is really important. So with that in mind, there's some data recently about what they call chronotherapy using osilodrostat. So those of you that aren't familiar with osilodrostat, it's a twice-a-day medication. It's much like metyrapone, so it decreases cortisol levels by decreasing cortisol synthesis. So when you give it twice a day, you kind of bring the levels down a little bit across the board. And what the investigators did here is they gave a dose kind of later in the day to really focus on dropping that evening cortisol level to a significant nadir. And when they gave that once-a-day dosing, they hit that lower nadir, and then they allowed the level to go back up in the morning, which really wasn't anything different than twice-a-day dosing. So those patients had better sleep, they had better quality of life. So, the question is, could we consider dosing like this with an agent that's normally twice a day and giving it once a day to try to get that nadir and let morning levels go up a little bit, or give doses that are kind of staggered, a smaller dose, a bigger dose to decrease the nighttime dose and a smaller dose for the morning, so that we have different levels, different times of the day. And then kind of putting this all together, if we're looking at adrenal nodules, everybody needs a dexamethasone suppression test. If that's abnormal, just making sure that patients don't have any other clear confounding reason why they have an abnormal DST. If it is abnormal, what's the ACTH and DHEAS? Make sure that it really is an adrenal problem, because there are lots of people that have ACTH-dependent hypercortisolism that have adrenal nodules. And then if you do diagnose adrenal Cushing's or MAX, we individualize their therapy. Do we send them for surgery? Do we follow them conservatively? And I'll mention that in a second, the word conservatively. Or do we think about enrolling them in a clinical trial of medical therapy? So thinking about the future and adrenal nodules in particular, some of the work from Alex Sternitz and Catherine that Alex presented in a poster in 2024 Endo was looking at screening for hormonal abnormalities in adrenal nodules. So as many of the people in the room know, that a few years back, the radiology department added a text when an adrenal nodule was identified on a CT scan. And they said, follow this link to see what you should do for adrenal gland workup, or go see the folks in the adrenal clinic. And we looked at a time period before that text and a time period after that text. And what you see here is numerically the screening rates in green, which are post-text, went up. Unfortunately, these aren't statistically significant. That may be some from the numbers, but numerically an increase. But I'd also point out that at the best, post for adrenal or for aldosterone, we're not even at 25% of adrenal nodules got screened. So even after that, we did kind of a lousy job. And I'm going to skip this slide. It's really just looking at the data in a little different way. So with that in mind, I think some future directions. One of the things that we're hoping to do at UW, some work that hopefully I'll be involved with here very shortly, is that looking at when the adrenal nodule is identified and actually actively sending a message through the EMR to the ordering provider that says, this needs to be worked up, or they can get referred in this way. So we're hoping that that active communication will actually increase screening rates, as opposed to sort of the passive radiology text that has been used at a lot of different institutions, including here at MCW. And then finally, what about treatment? Well, I think that we really need to figure out what's the best treatment. We just don't know. I have conservative comorbidity management listed here, and I think that that's the wrong way. And I've said conservative the whole time. I want to stop and say, let's reframe this. I think it should be aggressive comorbidity management, because really everybody should get aggressive management of their diabetes, hypertension, obesity, all these things we should think about and really aggressively treat them. And if we're going to look at clinical trials of what's better, the control group has to be aggressive comorbidity management. So we really need to focus on that versus surgery versus medical therapy. Again, the trick with medical therapy is what agent, what's the goal, but I think we really need to figure out what it is, because now we have 5 different agents we can use for, well, some form of cortisol excess. We've got lots of different FDA-approved cortisol synthesis inhibitors and other off-label agents. We've got glucocorticoid receptor antagonist. And I think one of them, if not multiple options, we should investigate those to see if they help patients that have MACs. So I've kind of been all over the place in terms of overt Cushing syndrome, MACs, this group in the Catalyst trial. Hopefully nobody fell asleep, so we're good. Otherwise, thanks, and I will happily take questions with plenty of time to go. I'm even going to give you the mic so I don't have to repeat it. Look at that.
All right. So, the number of people in the Catalyst trial, about 1,000 people, and there's 25%. I mean, there is a precedence for patients with uncontrolled diabetes having what we used to call pseudo-hypercortisolism. What about beyond diabetes? I mean, this seems like a really high number. And we don't know chicken or egg question. So what about distress of other kinds? I mean, diabetes is associated with distress. So what if you took 1,000 people of another kind of distress and tested them? Would you think that they would be also hypercortisolism?
Yeah, I think so. I'm not sure that mic's working, so I'll repeat the question. So the question is, what about, maybe Angela can tell us if it is, she'll pop her head in. Probably not. So the question is, what about other situations other than diabetes? If we tested patients that have other comorbidities, would they have excess cortisol? I think the answer is yes, if we pick the right comorbidities. There's good literature about depression and other mental health disorders, and so we know that that cortisol blockade may be beneficial in some of those settings. We know that those levels are high. I think it just depends on what condition we pick. I do think that we're going to find a lot of people that have high cortisols. What I don't know is if we treat those, do they get better? This trial would suggest that the answer for diabetes is yes. that's what it suggests. It's one trial. It's a relatively small number of patients. 90 patients got therapy. There are side effects from medication. So I think we need to continue to look. And maybe just because it's not good old-fashioned Cushing syndrome, maybe it's non-neoplastic hypercortisolism, maybe that still needs to get treated. I don't know.
So if you're seeing quarter people with the variety of distress, so I think that's a huge group of people.
Yeah.
If we were to, the other specific to diabetes,
It's because your mic is so. Sorry,
Oh.
it's just because this is turned down so low because
Got it.
that's so high that
You
this
know what?
isn't working.
I'll do this. You give them that.
Okay.
Yeah, see.
so I have one more question about any drug that now gets approved for either obesity or diabetes, they need to show cardiovascular outcomes. So now, what's your expectation? I don't know if the phase 2 trial, when they are going to treat, are they going to be looking at cardiovascular outcomes? It takes 5 years.
Yeah, I mean, the problem with this, certainly the group that has uncontrolled diabetes and positive DSTs is a bigger group than patients that have Cushing syndrome. But it's still a pretty small group and trial compared to the diabetes meds where we're talking thousands of patients followed for a long period of time. I don't know, the fervor with which the companies are going to look for additional FDA-approved indications. They may. And like you said, if we're talking about that, they may have to prove cardiovascular risk. The caveat here is that it's not a diabetes or a hypertension drug. It's a cortisol drug. And so the FDA has been weird about what labs they require. For Cushing syndrome, they always make people get enrolled in trials that have high UFC, which is a problem. So hard to know what they're going to say.
So they're not going to approve it for diabetes, but approve it for cortisol.
Yeah, I mean, if you look at the actual indication for mifepristone, it's patients that have diabetes due to hypercortisolism. So.
Hi, go ahead.
Go ahead. Jay's got a question first. We'll let him ask, and then you, Joe.
Well, I just want to amplify Dr. Ganabi's point. Yeah, I mean, many conditions, and poorly controlled diabetes being one of them, would have hypercortisolism if you define that as an abnormal dexamethasone suppression test, including depression. In fact, in the late 70s and early 80s, when I was a fellow, a guy at the University of Michigan, whose last name happened to be Carroll, was promoting the overnight 1 milligram dexamethasone for diagnosis of depression, and demonstrated that with effective therapy, whether it be psychoanalytic or in those days, I think benzos and a few other things were just emerging on the market, that the dex depression became normal, and that was a reflection of improvement in depression. Similarly, I think in this Catalyst trial, my guess is that this poorly controlled diabetes with mifepristone or whatever other treatment you may employ, that the hypercortisolism may also be reversible. So this is not necessarily a permanent part of the picture, and reversing it may be beneficial, because if you take somebody's hemoglobin A1C from 8.8% to 7%, good glycemic control begets good glycemic control, and my guess is that's and these were a difficult group of patients, very difficult.
I think it's a really good point that maybe, this is just interrupting the cycle. So patients that have poorly controlled diabetes, if they're treated with mifepristone, their diabetes gets better. We stop the mifepristone, their diabetes control continues to be better. That may happen in some patients, and they might not have abnormal dex suppression after that.
And to just amplify the point, it'll be at Endo in Chicago, the Momentum trial, which is where they took over 1,000 patients with resistant hypertension on multiple drugs and did the same thing, did dex suppression tests. And I'm not at liberty to tell you what the data shows, but let's just say, not surprising, a huge number of patients had abnormal dexamethasone suppression tests. So, I mean, I think it just amplifies this point that Vinny made.
Great. Joe, you had a question?
So thanks, Ty, for that great talk, and it's good to see you still standing after 3 or so months as a section head. But
Agreed.
my comment, maybe it's inherently obvious, and I haven't really thought of it this way, but I probably should. It strikes me in the patients with MACs who we are not operating on, we should consider the bone management the same as a patient on steroids and apply the steroid guidelines, which are different than regular osteoporosis guidelines to those patients. Does that seem like a reasonable idea?
I think that that's a really good idea, Joe, because if you think about the amount of prednisone in some of the steroid guidelines, we're talking about 5 milligrams of prednisone a day,
Right.
which isn't very super physiologic. Some people would argue it's about physiologic. I would disagree. I think it's a little super physiologic, but we're talking about people with MACs that it's a little super physiologic. So yeah, I think that we probably should be treating, patients that have a much lower predicted fracture risk, and treating them like they have steroids on board.
Thanks.
Dr. Troy? Yep.
Good to see you after.
Nice to see you.
I always have this question that I was afraid to ask. That was that the metabolic syndrome, you think it might be related to some of the adrenal cortex?
Yeah. So, I think in some ways that the metabolic syndrome, and again, I think it's this whole chicken and egg. Is it that patients that have cortisol excess are more likely to have weight gain, hypertension, lipid disturbances? Yes. Or are those things driving excess cortisol? And I don't know how we figure that out, but just kind of consider that there is an interplay there, and maybe interrupting one of the arms of that circle is going to help. And that's why, this Catalyst trial where they gave, mifepristone to block cortisol, I think it's helps metabolic syndrome, diabetes, all these things.
If you can identify the mechanism, that would be a great.
If you let me know the mechanism once you figure it out, we'll go in and the Nobel Prize together. Okay.
One more question.
Sure.
My endocrinology knowledge go back to 1960s. We stop there. We used to do metapyron test, 11-hydroxylase inhibition. We don't do that anymore, right?
We should. It's probably making a comeback. Yes, it actually is probably a much better test for secondary adrenal insufficiency. And now that metyrapone is made by a different manufacturer, it's a little bit easier to get. You might see it come back in vogue because that's the only thing that's FDA approved for in the U.S.
1959.
1960.
1959. It's never been approved by the FDA for treatment of hypercortisolism.
One more question, final question. Metapyron is inhibiting 11-hydroxylase. You think you can develop that as cortisol inhibition?
Yeah, I mean,
medication?
The newer agent, osilodrostat, is very similar to metyrapone in terms of where it has blockades. Yeah. Little different potency, but they've essentially used a molecule that's similar to metyrapone. So yes, and for years, metyrapone is used off-label as a treatment for Cushing syndrome.
All right. Thank you for allowing me to ask stupid questions.
No, you're very welcome. Jenna, you get the next one.
Hey, Ty, I have also a question.
Oh, you get the two down the line. Jenna's first.
So in the meta-analyses that you showed with adrenalectomy and MACs,
yep.
Are they age stratified at all? Like, is there more benefit for younger people versus older people?
Yeah, no is the easiest answer here. So the randomized studies, if you look at the numbers, are really small. And the cohorts are a little bit bigger. You get a few more numbers in the cohorts. And so I think that's a valid point. I don't necessarily treat somebody that's 30 the same way I treat somebody that's 85. Yeah. But I don't treat 85-year-olds the same as 30-year-olds in almost anything. So I think it's, reasonable. Again, consider the patient, individualized treatment. But I think it's a really good point. But who knows? Maybe the patients that are older have more benefit. I mean, we see that with osteoporosis drugs. The patients that are the highest risk are the patients that benefit the most.
Thank you, Dr. Carroll, for such a great talk. My question
Microphone.
is, patients who have MACs and sometimes they have bilateral adrenal nodule, which one to pick from and which of the adrenal gland to remove? Do we do like an AVS before?
Yeah, great question. The easiest answer is close your eyes and pick a side. No, we tend to go with the larger adrenal gland or larger adrenal nodule. That probably is the right answer. The problem becomes if they're similar in size. If they're similar in size, then adrenal vein sampling for cortisol has its own nuances. So, we have a protocol here that we use at MCW, same protocol at UW and Mayo. So you can use that if you can't pick a side. And I think that's a great example of a patient that we need to know, does medical therapy help? Because maybe those are the ideal patients for medical therapy. All right. Abu Bakr, you had a question?
Yeah, I had 2 questions. Thanks for coming. Great talk as always. My first question is regarding the candidacy of surgery. Depending on if they have like a max or mild cortisol excess, that's adrenal versus pituitary. Like if you have the 2 patients with the same, like a comorbidity profile, would you be more excited in doing surgery on the adrenal one rather than the pituitary one, or how do you, and any insight on that part?
Yeah. So let me answer that one first. I think, I kind of just lump cortisol excess as cortisol excess. It's maybe not true, but if I'm sure that somebody has cortisol excess and it's a pituitary source, almost uniformly they go to surgery unless there's some major reason why they can't. I guess with adrenal, now I'm going to go back on exactly what I just said. I individualize the treatment. If it's really mild, they just have diabetes that's well controlled. They're older. We discuss things. They don't really want to have surgery. And those might be the patients that I follow. I can't say that I really follow any pituitary Cushing's patients. I don't know, anybody else in the room follow any pituitaries? No, not really.
They don't want surgery.
Yeah, and then if they don't want surgery, then we're doing medical therapy. So great. And then second question.
My other question is in these patients who you don't know which is the chicken, which the egg is, do you sometimes consider doing some medical treatment, and then if there is improvement and patients want to do surgery, proceed with that, or that's not an usual approach?
Yeah, I'll say it's not the usual approach, but I've certainly thought about it. I think that there's some people have enthusiasm to kind of say that the pre-treatment or see if treatment makes things better. I'm not sure we're at a point where I think we need to do that. I haven't personally. I think that treating the hypercortisolism is beneficial over not doing it. Now we can argue that point, but I kind of say if we're going to treat somebody, that's kind of the first fork in the road. So do they want any treatment at all? Yes or no? And if they do, then is it surgery or medical? I have way far fewer patients who've opted for medical therapy as opposed to surgical therapy. I mean, lots of patients we send to surgery, pretty low morbidity in terms of surgery. So I really try to decide whether I think they need cortisol lowering or not, or we can follow things conservatively and then decide what's the best avenue after that.
Thank you so much.
You bet.
I was in an argument with somebody at the NIH this week about, he was saying that abnormal dexamethasone suppression testing is not hypercortisolism. I'm not sure what she wants to call it, but it doesn't really matter. But, and I made this point to her, I said, listen, if you look at Oxana Hamidi's study that Catherine and Ty and I were part of, in which the max patients, a huge number, what, 270 max patients who had adrenalectomy, 54 and 130 of them or more of them came from this set from MCW. 54% had post-op day one adrenal insufficiency. So my question is, apparently their hypothalamus and pituitary gland must have thought that they had hypercortisolism. I guess. I mean, at least nobody told them they didn't. And so the point is that since and we can't, and as you know, we can't predict even who the patients are. It does suggest that a very large number of these patients probably have clinically significant hypercortisolism if you extend it over years. I mean, if you're 52 years old and you have this, I mean, it doesn't portend, it's not reversible, spontaneously reversible. So some treatment intervention, or at least certainly close scrutiny and follow-up, seems very much warranted. And
I would agree, and I just had to scroll back to this slide because I put this in about progression because maybe that same individual and studies from there were the ones that said that if you had hypercortisolism, an abnormal test, and you didn't progress over that period of time, well, then you didn't have Cushing syndrome, and that initial test was a false positive. So our understanding of things changes over time.
I just want to make a comment. It seems like primary hyperparathyroidism to me. So, primary hyperparathyroidism for longest time, its observation is mild over the course of the years. You just kind of, right? So how did they come up? So is adrenal gurus going to come up with some kind of criteria? Like, it seems like that's what you would need, right? Something like whatever it is.
Yeah, I mean,
to help people
I
send to surgery.
think there's very few conditions that we take care of that we have decided we should treat less over the past 20 to 30 years. And we're now treating more and more mild cases of pick what it is. The only exception that I can think of off the top of my head is papillary thyroid cancer. Other than that, we treat more mild primary aldosteronism, primary hyperparathyroidism, diabetes, dyslipidemia, all these things. The more mild, 30 years ago, if your LDL was 110, yeah, that's great. Not so much anymore.
Well, listen, I'm so old that, when I was a fellow, I mean, the fellow should know this. If we saw a patient with spontaneous hypothyroidism, not thyroidectomy, radioactive iodine, I'm talking about that was so unusual that all the fellows would all come in the room and we'd see the patient, check the myotonic deep tendon reflexes. That's how I'm not making this up. That's how we monitored the patients. Because we actually measured the relaxation phase. So we thought that hypothyroidism was an unusual disorder. Okay? And then in the 80s, of course, the TSH was either greater than 10 or less than 10. That was the reference range. So which I think probably would be a good thing now too. So, but then in the 80s, it says TSH, we found all these people with TSHs of 11, 8, 9.
Yeah.
Oh my God, it's a public health problem. And now levothyroxine is the most commonly prescribed medication in the United States. Thyroid hormone, maybe not just levothyroxine, but thyroid hormone. So, I mean, it just goes to show you that now, obviously, giving thyroid hormone is a little bit different than doing a treatment or giving mifepristone. I understand that. But my point is, we thought hypothyroidism was unusual.
Hey, Jay, to kind of emphasize what you just said, we would truly be better off if we couldn't measure TSHs other than greater than 10, because the vast majority of patients with TSHs between the upper normal limit and 10 get no benefit from treatment, and we probably do no harm. We probably do more harm.
Well, I mean, I'm not a TSH expert, but
yeah, I mean, it's diseases like this change. I mean, Brad, when you were a fellow and I was a fellow, isolated central adrenal insufficiency, devoid of someone taking steroids, didn't really happen, right? I can't remember seeing a case. Now, how many cases of that do you see a week? 3, 4, 5 because of immune checkpoint inhibitors. So the landscape changes. Great, it's 5. So I will say thank you everyone for the questions and discussion.